Welcome to Literary Insights. This is the summary of the book The Balanced Brain, Camilla Nord. If you like this content, please consider mental health can have different meanings to different people, and there is no universal definition. Neuroscientists study it through things like clinical measures, well-being indices, brain chemicals, behaviors, and brain activity. The book will explore what neuroscience reveals about feeling better momentarily, pleasure, hedonia, or durably, life satisfaction, eudaimonia, and how our experiences shape our sense of mental well-being. The author views mental health as a type of balance or homeostasis in the brain, similar to the body's maintenance of stable internal conditions. Maintaining a balanced brain requires flexibly responding to internal and external challenges from our environment through change. That covers the key ideas presented in the introduction regarding the author's perspective on mental health and the scope of topics that will be explored in the book. Here are the key points about where mental health comes from based on the summary. Mental health is supported by many biological processes in the brain, including those related to pleasure, pain, motivation, learning, etc. These brain processes are shaped by both genetic and environmental experiential factors throughout one's life in complex interactions. Things like life experiences, social economic factors, diet, physical health can all impact mental health via effects on the nervous system. The brain's ability to predict events and learn from surprises, both positive and negative, is important for mental health. Positive mental health partly depends on expectations being slightly better than what happens. No single intervention works for everyone because mental health is unique to each individual based on their biology and experiences over time. What helps one person may do nothing or even harm someone else. Understanding mental health is important because mental illnesses are a leading cause of disease burden globally and can severely impact quality of life. Finding effective treatments requires understanding these complex biological and experiences factors. Mental health is closely linked to experiences of pleasure and pain. Conditions like depression involve a loss of pleasure, anhedonia. Pain is also associated with worse mental health. People who experience chronic pain are more at risk for mental illness. Studies show shared brain changes between chronic pain and mental health conditions. The brain processes pleasure and pain through neural pathways and circuits. Variations in these systems impact individual differences in what people find pleasant or painful. Experiencing pleasure and pain influences what the brain learns, what motivates behavior, and overall mental health. Changes in these systems can be a warning sign of declining mental health. In threatening situations, the body releases stress hormones that temporarily reduce pain sensitivity, stress-induced analgesia. This evolved to help survival by not distracting from threats. Variations in this response exist among individuals. Understanding the brain system's underlying experiences of pleasure and pain may help develop new approaches to mental health by targeting these pathways and circuits. Studies from the 1980s showed that brief stressful experiences like cold water swimming can induce stress-induced analgesia in rats, reducing their pain responses. This is due to the release of endogenous opioids, endorphins, in the brain. Stress-induced analgesia exists because mammals have an endogenous opioid system in the brain that is activated by painful, stressful experiences. Opioids suppress pain and induce feelings of euphoria. Brief stressful experiences can activate this system in humans and reduce pain sensitivity temporarily. One study found skydiving reduced pain sensitivity through opioid release. Chronic pain is different. It can cause hyperalgesia, where the nervous system becomes oversensitive to pain even after tissue damage heals. This is thought to involve changes in brain regions involved in bodily awareness, attention, and emotion. Chronic pain is strongly associated with increased risks of mental health disorders like depression and anxiety. This relationship is likely bidirectional, as mental health issues may also increase risk of developing chronic pain. The brain regions and physiological processes disrupted in chronic pain overlap significantly with those involved in mental health disorders. This suggests chronic pain shares more similarities with mental disorders than short-term pain responses. Pleasure is mediated by the release of opioids and other neurotransmitters in the brain in response to rewarding experiences like food, sex, social bonding, etc. Pleasurable experiences have been shown to reduce pain, similar to how stress skydiving induce analgesia through chemical changes in the brain. Early studies locating the brain basis of pleasure involved recording rat brain activity during enjoyable versus less enjoyable tasks and correlating it with observable liking behaviors like lip licking in response to sweet tastes. However, interpreting an animal's behaviors as indicative of an internal mental state like pleasure is problematic, as there is no way to directly check what the animal is experiencing, the mental inference fallacy. More advanced techniques are needed to directly measure pleasure in the brain, since focusing only on associated behaviors makes it difficult to separate pleasure from other drives that could produce similar responses. Overall, investigating the neurobiology of pleasure and pain involves challenges in objectively quantifying subjective internal experiences. Measuring pleasure or other experiences in humans is easier than animals, as you can directly ask humans how they are feeling. Common techniques like fMRI and PET scans are used to measure brain activity in humans during pleasure tasks, but they have limitations and can only approximate neural activity. Early pleasure experiments using fMRI found certain brain regions like the orbitofrontal cortex correlated with experiences like drinking chocolate milkshakes. However, patients with damage to these regions could still feel pleasure, indicating correlation does not equal causation. Just because an area is activated during pleasure does not mean it causes pleasure. Some brain regions called hedonic hotspots have been found that do directly generate pleasure sensations. Their activity causes pleasure experiences. It's important to have converging evidence from both human and animal experiments to more confidently determine what brain areas or chemicals can cause experiences like pleasure or pain. Correlation alone is not sufficient to claim causation. In summary, the passage discusses some of the techniques, insights, and limitations of measuring pleasure and other experiences using human neuroscience and brain imaging methods. It emphasizes the importance of converging human and animal evidence to make causal claims. Scientists have mapped hedonic hotspots or pleasure centers in the brain by directly injecting drugs into specific brain regions in animals. These hotspots involve a network of small, distributed regions that work together. Stimulating these hotspots, either through drugs or natural activities, can directly cause pleasure and enhance liking of rewarding experiences. Opioids and endocannabinoids both activate the nucleus accumbens hotspot. While drugs can access these pleasure pathways, most pleasure comes from natural activities like laughter, sex, and music. Prescription opioid drugs are effective for pain relief, but carry addiction risks. They activate the same pleasure systems as natural opioids released during activities like social. One study found social laughter with friends increased natural opioid release in the brain, causing feelings of calmness and happiness. It also increased pain tolerance, showing laughter can relieve pain through opioid activation, similarly to drugs. Laughter's ability to trigger mass opioid release may facilitate social bonding and group cohesion, providing an evolutionary advantage for survival. Alternative pain treatments are needed to avoid addiction risks from opioids. Here is a summary of the key points. Researchers Scott, Carolyn McGettigan, and Nadine Levon have conducted experiments showing that laughter serves not just to promote social bonding, but also regulates negative emotional experiences. Laughter can immediately lift mood and have long-term benefits for relationships. One study showed couples who laughed more during arguments experienced lower physiological stress levels. The ability of laughter to reduce marital stress can improve overall well-being by boosting relationship satisfaction. Laughter fulfills multiple functions, providing momentary pleasure, pain relief, and facilitating social bonding. These benefits may improve quality of life. Regular experience of pleasure is strongly associated with better mental health and life satisfaction. While correlation does not prove causation, things that cause pleasure like laughter seem to actually increase happiness. The relationship between well-being and pleasure is likely bidirectional and self-perpetuating. For people struggling with depression or other mental health issues involving reduced pleasure, It can be difficult to engage in this upward spiral of increased well-being and pleasure. Lower levels of well-being are associated with less laughter, which produces fewer opioids, and therefore lower well-being in a negative feedback loop. Lack of pleasure, interest in activities, anhedonia, is a risk factor for poor mental health. It is assessed via questionnaires about satisfaction with activities. Anhedonia is a core symptom of depression, schizophrenia, addiction, and eating disorders. It can precede these disorders and increase risk of relapse. Anhedonia may be a transdiagnostic risk factor for poor mental health, as it reduces resilience to stress. Pleasure supports mental health via its effect on learning and motivation. Rats can be conditioned to associate pleasure with objects' contexts. Austerity is not the only route to mental health. Focusing on and maintaining pleasure can also support mental health by engaging brain circuits related to hedonia and positive mental health. Pleasure is complex, involving many brain regions and chemicals beyond just opioids. The context and one's internal bodily state also influence experiences of pleasure. The passage discusses the concept of hangry, feeling irritable or bad-tempered due to hunger. It summarizes some popular explanations for this phenomenon. One explanation attributes it to stress hormones released when blood sugar drops, which overlap with hormones related to anger/irritability. This could confuse the brain into feeling angry when hungry. Another explanation is that when the brain runs low on fuel, its ability to inhibit emotions decreases, so pre-existing irritability emerges when hungry. The author argues these don't fully explain why only anger tends to emerge with hunger. Emotions are influenced by both bodily states and the brain's interpretations of them. Experiencing an emotion involves both the body's state and how the brain interprets and contextualizes those feelings. A classic study showed that when given adrenaline but not warned of physical side effects, participants took on the emotions of a stooge in the room, happy or angry. Context shapes how we interpret and label our physiological feelings. So in summary, it discusses popular explanations for hangry and argues the full story requires understanding how emotions emerge from both bodily states and the brain's contextual interpretations of them. A classic study demonstrated the strong influence of context on how we experience our own emotions. Early experiments in the 1960s found that injecting adrenaline could influence emotion experience, suggesting physiological states influence emotions. However, subsequent studies failed to reliably replicate these effects. While arousal physiology can influence emotion interpretation, it is not fully malleable, and people may interpret arousal based on lifelong learning about what causes certain body sensations. Factors like hunger, stress, or past experiences can lead one to misattribute a physiological state like hunger as anger or vice versa. Interoception is our sense of internal bodily states. Signals from organs like the heart unconsciously influence emotions and behavior. Experiments show we are better at detecting fearful faces when they coincide with heartbeats. The gut microbiome and immune system may also play a role in mental health by communicating with the brain, though their exact effects require more research. In summary, while early views that physiology dictates emotions were too simplistic, ongoing research continues to show bidirectional relationships between our mental and physical states through mechanisms like interoception. Misattributions are possible due to the brain's imperfect ability to interpret physiological signals. This passage discusses how different organs in the body can influence emotional processing and responses in the brain. The heartbeat communicates threat signals to the brain to help detect danger. Studies show disgust is resistant to habituation even with exposure therapy, unlike fear. The author hypothesized this may be because disgust has a physiological signature in the stomach. When viewing disgusting images, the stomach's rhythm changes even without consciously feeling nausea. To test this, the author and colleague gave participants an anti-nausea drug or placebo while viewing disgusting images. Those on the drug became less avoidant of images, indicating the stomach state contributes to disgust avoidance. This suggests targeting the stomach may help exposure therapy for extreme disgust. The passage also discusses how general immune system activation from illnesses can cause widespread physical and psychological symptoms like depression. Studies link low mood to heightened blood inflammation markers. While poorer physical health or lifestyle factors may explain this, experiments show directly inducing inflammation can cause depressive symptoms. So inflammation may sometimes directly worsen mental health, though the relationship is complex. Inflammatory factors in the bloodstream typically increase temporarily in response to illness or medical interventions like vaccines. This temporary inflammation has been shown to cause depressive symptoms and brain changes associated with depression. The inflammatory response affects mood and mental health because inflammation causes changes in the brain regions involved in emotion, reward processing, and interoception, bodily awareness. This can make people more sensitive to punishments and less sensitive to rewards. Not everyone responds to inflammation with depression. There are individual differences. Inflammation may cause depression through different immunological pathways in different people. Evidence suggests there may be subgroups of depression, some associated with increased inflammation, inflamed depression, and some not, uninflamed. Even within inflamed depression, there may be different types based on the specific inflammatory factors involved. The gut microbiome, or bacteria in the gut, is also thought to influence mental health by communicating with the brain. However, most robust studies on this are done in rodents, not humans. More research is still needed to establish causal links. Early life experiences, like birth method, antibiotic use, and diet, can shape the development of the gut microbiome in ways that may impact long-term behavior and mental health, at least based on rodent studies. But human studies have not found clear causal relationship. Here are the key points about the relationship between certain antibiotics and risk of mental health problems. Studies have found associations between the gut microbiome and mental health conditions like depression. Certain bacteria in the gut, like Faecalibacterium and Coprococcus, have been linked to better quality of life and lower depression risk. Antibiotics can disrupt the gut microbiome and deplete certain beneficial bacteria. This may increase the risk of mental health issues like depression by altering the microbiome-brain axis. However, the evidence is still preliminary. Temporary disruptions to the gut microbiome from antibiotics do not seem to noticeably worsen mental health in experiments. More research is needed to establish a direct causal link between microbiome composition and mental health in humans. Other factors like diet, inflammation levels, and general bodily health signals may also play a role in the gut-brain connection. Improving the gut microbiome alone may not be the sole determinant of mental health outcomes. So in summary, certain antibiotics have been associated with microbiome changes that could increase depression risk, but the nature of the gut-brain relationship requires more conclusive evidence. A number of other physiological systems are also likely involved. Functional neurological disorders involve physical symptoms like weakness or tremors that are caused by abnormal brain functioning rather than structural damage. Their patterns of reflexes differ from neurological diseases. They are not caused by patients faking symptoms. To patients, functional disorders feel just as real as symptoms from neurological diseases. The brain shows different activation patterns compared to faking. Functional disorders can be as debilitating as neurological diseases. A common misconception is that they should be easier to overcome since they are just functional, but this is insulting to patients. Risk factors include previous physical injuries. Functional disorders are often misdiagnosed as patients get passed between neurology and psychiatry without treatment. They demonstrate how the brain can alter the physical body. The brain's software of expectations and perceptions can generate real physical symptoms. Causes may involve the brain becoming hypersensitive to bodily signals after injuries or illnesses. Strong expectations of symptoms from the brain can lead to those symptoms manifesting physically. Mental health disorders also involve changes in how the brain interprets bodily signals, demonstrating the interconnection between physical and mental health. The chapter discusses how the brain learns to maximize survival chances by learning rewards and punishments. It learns which actions lead to rewards and which lead to unpleasant outcomes, so it can seek rewards and avoid punishments. This learning involves predicting outcomes based on past experiences. When predictions are violated, e.g. getting unexpected reward or punishment, it creates a prediction error signal that causes the brain to update its prediction. An experiment in monkeys showed that dopamine neurons fire in response to unexpected rewards, but shift their firing to predict reward-related cues once the rewards become expected. This showed dopamine plays a key role in encoding prediction errors that drive learning. Based on prediction error signals, the brain constantly updates expectations about what will lead to rewards or punishments. This underlies how we learn environmental and social contingencies that influence well-being and mental health. So in summary, dopamine cells in the brain encode prediction errors, firing more when an outcome is better than expected and less when it is worse than expected. This helps the brain learn and optimize future predictions. Neuroscientists studying dopamine cells were inspired by reinforcement learning algorithms in AI that also aim to minimize prediction errors through trial and error. Studies in monkeys and humans show dopamine cells shift their firing from encoding prediction errors to anticipating rewards after learning. This allows the brain to anticipate and prepare for rewards. Experiencing positive prediction errors when things are unexpectedly good has been linked to short-term increases in happiness and well-being. This effect is thought to be driven by dopamine release. Prediction error signaling is important for learning, motivation, and survival by helping the brain accurately predict rewards and outcomes. Disruptions to this system could undermine mental health. Emotions represent short-term fluctuations in feelings, while moods are longer-lasting states that color emotional experiences. Maintaining a relatively positive mood, even when negative emotions occur, is important for mental health. Mood states can become self-reinforcing attractor states, where one is pulled back to their current mood even when good things happen. Depression is associated with blunted reward processing, lower expectations of reward value, and disrupted learning from rewards. Unexpected good events have less impact on maintaining a positive mood. This is due to reduced reward-seeking behavior, limiting positive experiences, and disrupted learning, meaning few rewards experienced don't impact future expectations. Depression is also linked to enhanced negative processing, greater impact of punishments and failures on learning through things like catastrophic responses to perceived failure. The habenula is a brain region that signals punishment prediction errors. Animal studies found heightened habenula activity in depression-like states. However, a study using advanced fMRI found the habenula actually signaled punishments less in human depression. This was surprising, but could still disrupt learning to avoid punishments. Both blunted reward and enhanced negative processing reinforce low mood by changing what events impact one's expectations and behavior through prediction error learning mechanisms. Our sensitivity to reward and punishment plays a key role in vulnerability to mental illness. Stressful experiences can change how the brain processes positive and negative outcomes, increasing vulnerability to depression. Differences in how the brain learns from rewards punishments can confer both vulnerability to depression as well as resilience. Resilience may involve learning more from small positives and adapting well to negatives. Dopamine is important for learning and mood. Directly increasing dopamine through drugs can cause short-term euphoria, but not sustained improved mood and risks addiction. Subtle cellular changes in brain regions involved in learning, in response to stress, may underlie vulnerability resilience to depression. Animal studies show excess dopamine firing in depressed mice, but normalized firing in resilient mice, despite larger excitatory currents, suggesting homeostasis mechanisms. There are likely multiple paths to depression via disrupted learning systems. Treatments targeting specific symptom-causing processes may be needed, as no single treatment will work for all individuals with depression. Improving responses to negatives may help preserve mental health. In the 1950s, Donald Hebb at McGill University helped pioneer the modern field of neuroscience by showing that neurons that fire together wire together, known as Hebbian plasticity. James Olds, a social psychologist influenced by Hebb's work, trained under Hebb at McGill University. There he met Peter Milner, a neurophysiologist. Olds and Milner conducted experiments where they implanted electrodes in rat brains and found that rats would repeatedly press a lever to stimulate certain brain regions, suggesting these regions played a role in motivation drive. Their work suggested drive motivation was an essential but overlooked component of mental health and well-being. While not a happiness switch, their experiments showed the closest thing to flipping a switch to change behaviors and mental states at the time. Their research helped establish that behavior could be explained by brain function and laid important foundations for understanding the brain basis of mental health, though the outcomes were darker than simply increasing happiness. James Olds, a psychologist, was working with neurophysiologist Brenda Milner, conducting experiments implanting electrodes in rats' brains to study learning and reward pathways. In one experiment, Olds accidentally implanted an electrode in the septal area rather than the intended region. They discovered rats would press a lever to stimulate this area, indicating they found it rewarding. Further experiments showed rats would press the lever thousands of times per hour, even enduring shocks, to receive stimulation of this region. This raised questions about what experience the rats were having. Similar results were later found in many other animal species when stimulating comparable brain areas. This led some psychiatrists like Robert Heath to conduct human experiments in the 1950s-60s, implanting electrodes in patients, including some involuntary ones. Heath's experiments found brain stimulation could produce subjective, pleasurable experiences in humans. However, they also had unethical dimensions and side effects, like severe addiction to self-stimulation in some patients. The discovery of brain reward pathways had both advanced scientific understanding, but also been pursued in a reckless and harmful manner. Here is a summary of the key points. Heath's experiments on humans stimulating brain regions involved in reward and motivation raised many ethical concerns that were not fully addressed at the time. While patients seemed highly motivated to continue receiving stimulation, it is unclear if they actually experienced pleasure. Their behavioral changes could reflect increased motivation drive rather than subjective pleasure. Stimulating these brain regions in both humans and rats seemed to override other drives like eating or hygiene, prioritizing obtaining more stimulation. But this does not prove the stimulation was enjoyable. Increased motivation drive is an important component of mental well-being, helping ensure survival behaviors, but it does not necessarily cause pleasant subjective feelings. Dopamine is a key neurochemical involved in both increased motivation from brain stimulation and from drugs like mephedrone, MCAT. High dopamine can amplify motivation drive without direct pleasant effects. Early discoveries about dopamine's role in movement, not reward motivation, helped reveal it as an important neurotransmitter in its own right. The summary focuses on the uncertainty around whether brain stimulation caused actual pleasure, the distinction between motivation, drive, and pleasant feelings, and dopamine's role in both stimulation effects and drug effects by amplifying motivation. It avoids directly describing unethical aspects for legal, ethical reasons. Researchers wanted to test the hypothesis that noradrenaline deficiency causes Parkinsonism, difficulty initiating movement. They couldn't directly inject noradrenaline due to the blood-brain barrier, so they injected L-DOPA, which converts to dopamine in the brain, and then dopamine converts to noradrenaline. Injecting L-DOPA cured the Parkinsonism in rats and rabbits, but their noradrenaline levels did not change. To their surprise, their brains had higher dopamine levels, suggesting dopamine may be a neurotransmitter itself, rather than just a precursor. This discovery led to the use of L-DOPA to treat Parkinson's disease in humans. L-DOPA replenishes lost dopamine and improves movement symptoms. Dopamine has roles in both movement and reward motivation pathways in the brain. Loss of dopamine can cause apathy, lack of motivation, in addition to movement problems. L-DOPA treatment helps both movement and apathy for most, but some patients develop impulse control disorders due to effects on reward pathways. Individual neurobiology influences susceptibility to apathy, impulse control disorders, and addiction related to dopamine function. Placebos can effectively treat conditions like phobias, pain, and irritable bowel syndrome. Many people attribute improvements in their health after treatment to the ingredients, but it could sometimes be due to expectations and the placebo effect. Homeopathy seems to work for some people based on their experiences, even though clinical trials show it is no more effective than a placebo. Placebos can work extraordinarily well to make people feel better. Placebos exemplify how mental processes can change physiology. Beliefs and expectations that one will get better after treatment are built up over experiences with various medications improving conditions. This creates an expectation of improvement even with new treatments. The placebo effect comes not just from taking a pill, but from the entire treatment ritual, seeing a provider, getting a prescription, etc. This activates neurobiological pathways related to reward, anxiety reduction, and healing that can induce physical changes and alleviate symptoms. While placebos may seem like just a trick of the mind, they are an advantageous feature of how our brains work to promote health and recovery through expectations and meaning. Responding to placebos is a capacity all humans have. Placebo effects originate from both expectations conveyed by medical practitioners as well as expectations from friends and family. Having people in your life telling you treatment will make you feel better reinforces expectations of recovery. Over time, as most treatments do make people feel better eventually, the belief that medicines lead to wellness becomes stronger. This increases the likelihood that future treatments will be effective via placebo effects. However, placebo effects alone are generally not sufficient to effectively treat medical conditions where established treatments exist, like chemotherapy. Placebos work best when combined with active pharmaceutical ingredients. Placebo effects operate at an unconscious, implicit level of beliefs and expectations formed through experience, not just conscious positive thinking. Things like pill color can impact placebo responses without conscious awareness. Even when people know they are receiving a placebo, effects are still observed, showing how deeply rooted these unconscious expectations are. Placebo responses involve changes in brain regions involved in pain processing, decision-making, and reward-punishment systems. The specific brain changes depend on whether expectations are for relief or worsening of symptoms. Both placebo effects and nocebo effects rely on brain changes caused by unconscious expectations interacting with active pharmaceutical ingredients to determine treatment outcomes. Placebo responses are about more than just the drug alone. Here are the key points about how antidepressants work. Antidepressants are thought to work by modulating neurotransmitters in the brain, like serotonin, norepinephrine, and dopamine that are involved in mood regulation. Selective serotonin reuptake inhibitors, SSRIs, work by inhibiting the reuptake of serotonin, leading to increased levels of serotonin in the brain. This is thought to help relieve depression symptoms over time. Other classes of antidepressants like serotonin norepinephrine reuptake inhibitors, SNRIs, and norepinephrine dopamine reuptake inhibitors, NDRIs, have similar mechanisms targeting different neurotransmitter pathways. Antidepressants take weeks to months to start working as the brain adapts to the new neurotransmitter levels. This lag period is why compliance with treatment is important. Exactly how the changes in neurotransmitters translate to improved mood is still unclear. It may involve impacts on mood-regulating brain circuits and changes in neuroplasticity over time. The placebo effect also likely plays a role, as patient expectations of relief can induce real biological changes in mood circuits. But for moderate-severe depression, antidepressants provide benefits over placebo. Antidepressants are generally seen as effective long-term maintenance therapies to prevent relapse, but may not fully resolve underlying vulnerabilities or issues for some people. Psychotherapy can also help with this. More research is still needed on personalized medicine approaches and combinations with alternative adjunct therapies to help more treatment-resistant patients find relief. In summary, while the precise mechanisms are complex, antidepressants are thought to improve mood by modulating brain neurotransmitter systems implicated in depression over weeks to months of treatment. Compliance, psychotherapy, and precision approaches may also help maximize their benefits. Antidepressants are believed to work by fixing a chemical imbalance or deficit of serotonin in the brain. However, this explanation of depression as solely a serotonin deficiency is now known to be incorrect. While antidepressants do increase serotonin levels, they don't provide immediate relief of depressive symptoms. It usually takes several weeks of daily doses before an effect on mood is noticed. This delay was mysterious under the serotonin deficiency theory. Research has shown that low serotonin may trigger depression in some individuals, but is neither necessary nor sufficient to cause depression on its own. Antidepressants likely work through more complex mechanisms than just correcting serotonin levels. A leading theory today is that antidepressants change brain cell connections and signaling over the long term through neuroplasticity, rather than just acting on chemical levels. Their short-term effects may also better prime the brain for long-term changes. So while targeting serotonin and other neurotransmitters, antidepressants may work through longer processes in the brain rather than a simple chemical correction as initially believed. This could explain their delayed onset of action on mood symptoms. Cognitive theory proposes that antidepressants work by changing the way people think, remember, perceive emotions, and information in the brain. This is different from biological theories that focus only on their actions on brain cells or circuits. People with depression tend to have a negative emotional bias. They interpret ambiguous situations or facial expressions in a more negative way. Their emotional tipping point is lower. Antidepressants shift this emotional tipping point in a more positive direction even after a single dose. They increase attention and memory for positive information and decrease it for negative. Neuroscientifically, antidepressants decrease amygdala response to negative stimuli and increase response to positive. The amygdala is involved in emotion processing and memory. Over time, these subtle shifts accumulate and change the person's overall interpretation and expectations about the world in a more positive way, eventually improving their mood. However, having a negative bias is a personality trait and not necessarily something that requires treatment. Antidepressants target the bias specifically to help with depression symptoms when life is substantially impaired. The negative bias is shared by other disorders too beyond just depression. Here are the key points about whether antidepressants would work for you based on antidepressants only work for about half of people who try them, no matter the diagnosis. So there's no guarantee they will work. Different antidepressants may work better for different people. Not responding to one doesn't mean none will work. It's common to try multiple options. Depression is likely not one single biology or experience. Antidepressants target specific brain systems, so they may only help if your depression involves those systems. Personalized treatment aims to predict who will respond best to which option, antidepressants versus therapy or different meds. But we can't perfectly predict treatment responses yet. Factors like demographic data and symptom profiles have shown some ability to predict responses in studies, but algorithms have limitations predicting new patients. Understanding the biological mechanisms behind antidepressant effects may provide clues on who they help by targeting emotional biases, for example. So in summary, there's a chance antidepressants could work for you, but also a significant chance they may not, based on the complexity of depression. The best approach is usually to discuss options with your doctor. Antidepressants work primarily by targeting specific neurotransmitter systems like serotonin, but they don't work for everyone since depression has many biological causes. Placebo effects play a major role in whether antidepressants are effective for an individual. Both the drug and expectations of improvement contribute to outcome. While on average, antidepressants are more effective than placebo, some trials have not shown clear differences due to large placebo responses. This has led some to question whether antidepressants really work. However, the evidence from many independent trials overall does indicate antidepressants are generally effective compared to placebo, even if not for all individuals, or targeting a specific chemical imbalance. Their mechanism of action is likely more complex than simply correcting neurotransmitter levels and involves cognitive and emotional changes over time. As depression has many causes, future treatments may target other brain systems beyond serotonin to help more people. Considering effects on factors like emotional biases may also help predict treatment responses. Other drugs, both prescribed and recreational, can also impact mood and thinking, though targeting different systems than traditional antidepressants. Understanding these mechanisms could inspire new treatments. The passage discusses regulating psychoactive substances and how their risks and benefits should be evaluated based on scientific evidence, not just public perceptions or political opinions. It cites research by David Nutt analyzing the harms of various legal and illegal drugs. Alcohol was found to be one of the most dangerous drugs overall when considering both individual and societal harms. Drugs like magic mushrooms, LSD, and ecstasy were found to have very low risks of individual and societal harm, based on measures like mortality, health effects, crime rates, etc. Despite the scientific evidence, Nutt was fired from his government advisory role after stating alcohol is more dangerous than some illegal drugs like ecstasy. The passage argues drug policies should be based on rigorous assessment of a drug's actual risks and benefits to health and society, not other non-scientific factors. Nutt's research provided such an evidence-based analysis, yet was controversial politically. In summary, it discusses how recreational drugs should be regulated based on scientific evidence of their harms, provides an example of research on this, and argues current policies are not always aligned with such objective risk assessment. Cannabis laws and policy have not aligned well with scientific evidence on relative drug harms. Possession of cannabis can be punished by years in prison in the UK, on par with more dangerous drugs. The definition of psychoactive substances in UK law is extremely broad, potentially including common items like chocolate and tobacco. Exceptions had to be made for legitimate substances like food and alcohol. Enforcing drug bans comes at high financial and social costs. Cannabis legalization in some places has had benefits for public health and harm reduction. Cannabis constituents like THC and CBD can have differing, even opposing, effects on mental health. THC is linked to psychotic symptoms, while CBD may protect against them and reduce cannabis dependence. Street cannabis has shifted to being higher in THC over time, which could impact cannabis users' mental health. More research is still needed to understand the complex relationship between cannabis and psychosis. Here is a summary of the key points. Cave murals in southeast Algeria, dating back 8,000 years, depict local hallucinogenic mushroom species, providing early evidence of psychedelic use. The author had a personal experience with psilocybin mushrooms and noticed subtle effects on their appreciation of the sky that lasted for months after the single experience. In the 2000s, research on psychedelics began reigniting interest after being largely abandoned in the 1970s due to legal and social factors. Neuroscience studies explored the potential benefits of psychedelics for mental health. A landmark Johns Hopkins study found that a single controlled psilocybin experience was rated among the top 5 most meaningful experiences of participants' lives over a year later, with sustained increases in well-being. Effects were stronger than from a stimulant drug control experience. A 2014 clinical trial at Imperial College London found that all 12 treatment-resistant depressed patients showed reductions in depression symptoms 1 week after a psilocybin experience, with effects lasting 3 months for most. This provided early promising evidence for psychedelics as a potential treatment approach. A small early study found psilocybin to be as effective as the antidepressant escitalopram for treatment of depression, with 5 of 8 patients remaining in remission after 3 months. However, larger controlled studies are still needed. Psilocybin seems to globally increase brain activity when measured by PET scans, but decrease activity in some brain regions by fMRI. This may be due to differences in how the brain is measured and timescales involved. The precise mechanism of how psilocybin improves mental health is still unclear. It may change processing of emotions, rewards, and memories, but further research is needed. Psilocybin can cause temporary side effects like anxiety and nausea. Some patients have also reported longer-term distressing effects, so potential harms need more systematic study. Placebo effects are important to consider as open-label psilocybin studies lack blinding. Inert placebos have produced psychedelic-like effects in some, so placebo control is important. Psilocybin may cause a grander disruption in beliefs than antidepressants through sensory overload and relaxing constraints on beliefs, potentially breaking maladaptive mindsets in depression. However, more research with large controlled trials is still needed. Psychotherapy and drug treatments for mental health are often thought of as separate approaches, but they actually have more in common and can work together. Both affect the brain in overlapping ways to alter beliefs and expectations about the world. Psychological therapies like CBT aim to improve mental health by helping people reflect on and challenge unhelpful thought and behavior patterns. CBT is one of the most evidence-based therapies, particularly for depression and anxiety. CBT traces its roots to behaviorism and cognitivism. Behaviorism sees behaviors as conditioned by experiences, while cognitivism acknowledges various cognitive processes like thoughts, emotions, and memories that influence behavior. Though behaviorism and cognitivism differ in how they view the mind, they are clearly interlinked. Conditioned learning shapes cognition, and cognition shapes what we learn from experiences to alter behavior. In CBT, a therapist helps patients notice unhelpful behavior patterns by linking them to underlying thought patterns and challenges these thoughts to change behaviors and ultimately improve mental health. So both drug treatments and psychotherapy can work in similar ways to modify beliefs and outlooks. Here are the key points about how therapy works according to the passage. Cognitive behavioral therapy, CBT, aims to retrain a person's model of the world by challenging negative or unhelpful thoughts and behaviors. It uses both behavioral techniques, like exposure therapy, to face fears, as well as cognitive techniques to dispute irrational thoughts. Therapy takes time to work, as prediction errors need to build up to change patterns of thinking and behavior. It changes the brain through conscious reevaluation of beliefs, resulting in altered automatic interpretations and expectations over the long term. Different therapies may target different brain regions. CBT more, the medial prefrontal cortex involved in awareness; antidepressants more, the amygdala involved in emotion perception. For some people, changing cognition through CBT works better. For others, direct changes to emotion perception through medication works better. Therapy can fail if prediction errors are not able to shift an ingrained negative model of the world. Additional techniques may be needed to destabilize beliefs first. Improving learning from negative feedback is one way CBT could enhance mental health by helping integrate setbacks into expectations. So in summary, CBT aims to retrain thought patterns through a combination of behavioral experiments and cognitive restructuring over time, ultimately changing the brain. Variations in individuals impact which approach is most effective. Some people have a strong internal monologue or narration of their thoughts, while others do not. Those without an inner dialogue find it difficult to answer CBT questions about what they were thinking during past events. Both medication and psychological therapies like CBT can be effective for treating depression, but it's difficult to predict which approach will work best for any individual. Combining the two approaches may yield better results than either alone. CBT aims to change patterns of thinking, which can in turn affect mood and behaviors over time. Antidepressants also produce small changes in perception and interpretation that accumulate. Psychological therapies are commonly used to treat mental health conditions, but they can also positively impact physical health. This is because thoughts, beliefs, and expectations shape one's experience of both mental and physical symptoms. Conditions involving unexplained physical symptoms, like drop attacks, may be driven by psychological factors like trauma, attention, worry, and avoidance behaviors. CBT can help by changing how patients interpret and respond to physical sensations. While CBT helps many people, mindfulness-based therapies offer an alternative approach by cultivating present-moment awareness rather than attempting to change patterns of thinking. This can also beneficially impact mental and physical health. Mindfulness techniques train a style of thinking that accepts sensations and thoughts moment to moment without judgment, reducing connections between thoughts and emotions. This can help slow racing thoughts and the desire to use substances to cope. Paying close attention to momentary perceptions makes each sensation more specific and precise. This shifted attention reduces people's certainty about their beliefs and helps them realize they cannot control most events. Mindfulness is useful for maintaining mental health after recovering from depression and preventing relapse. Mindfulness-based cognitive therapy is commonly used as a relapse prevention program. Mindfulness teaches acceptance and breaking up negative thought patterns through self-compassion. It weakens unhelpful models of the world by diminishing the salience of negative information. Not everyone is naturally adept at mindfulness, even with practice. Some require more effort to regulate emotions and thoughts. Mindfulness may be particularly important for these individuals. While usually innocuous, mindfulness can in rare cases induce distressing dissociation in vulnerable individuals like trauma survivors. Psychological therapies also carry potential adverse effects not typically linked. Individual differences in brain circuits influence treatment responses. Baseline brain states may change how mindfulness impacts different people. Boosting treatments before therapy could optimize response by priming the brain. Memory training could help people plan for the future by coming up with specific plans, identifying potential obstacles, and developing strategies to execute their plans. It could improve their ability to think through challenges and respond effectively to therapy. Memory training indirectly affects the brain's state by engaging cognitive processes through exercises and dialogue, rather than direct chemical or electrical modulation like medication. However, medication could also be used to boost therapy in targeted ways. Psychedelic drugs have potential as therapy boosters because they can dramatically change one's worldview. They may work by enhancing cognitive processes important for therapy success. For example, MDMA helped PTSD patients engage with trauma-focused therapy when it would otherwise be overwhelming. Understanding how biological and psychological treatments interact on brain mechanisms can help bridge the gap between these approaches and lead to more effective, personalized treatment combinations. Indirect treatments like psychotherapy and direct treatments like brain stimulation both aim to remedy dysfunctional brain processes underlying mental health conditions. Brain stimulation involves applying electrical or magnetic currents to targeted brain regions to alter neuronal activity and treat mental health conditions. It offers an alternative to medications or psychotherapy by directly modulating specific brain circuits implicated in symptoms. The most well-known type is electroconvulsive therapy, ECT, which uses high-voltage electricity to induce brief seizures. Despite its negative portrayal, ECT is more effective than antidepressants for severe depression. Side effects include short-term memory loss, but studies show no evidence of lasting brain damage. Other forms of non-invasive brain stimulation include transcranial magnetic stimulation, TMS, and transcranial direct current stimulation, TDCS. TMS uses magnetic fields to stimulate neurons, while TDCS applies weak electric currents through electrodes placed on the scalp. These methods can target regions without surgery. While controversial, research shows brain stimulation holds promise as an additional treatment option when other approaches prove ineffective. Scientists are continuing to study its mechanisms and potential applications. The history of using electricity medically dates back to ancient times, but modern brain stimulation is more targeted and rigorously tested. In the 18th century, Benjamin Franklin experimented with using electricity to treat various ailments by having volunteers get electricized. He found only temporary improvements for stroke paralysis symptoms, which he attributed partly to placebo. Others in Britain also reported some successful electricity treatments, like restoring movement, which conflicted with Franklin's observations of no long-term benefits. Modern accounts suggest the successful cases likely had functional, non-physical conditions. Franklin thought short-term improvements were placebo effects. Others echoed this view, noting bigger batteries seemed more effective due placebo expectation effects. Placebos can be powerful. Electrical stimulation may have altered expectations and enabled new learning recovery in some patients with functional disabilities driven by psychological factors. Modern brain stimulation techniques like TMS and TDCS are investigated as potential treatments for depression. They aim to increase activity in the prefrontal cortex to improve focused decision-making. Several clinical trials found TMS reduced depression symptoms when given repeatedly over weeks, though it did not work for all. The author's own trial found adding TDCS to therapy did not significantly improve outcomes over placebo stimulation plus therapy. Reasons for inconsistent results are discussed. Deep brain stimulation, DBS, was originally developed to treat Parkinson's disease by targeting dopamine circuits. It involves surgically implanting electrodes into specific brain regions. In the early 2000s, Helen Mayberg conducted the first trial of DBS for treatment-resistant depression. Electrodes were implanted in the subgenual anterior cingulate cortex, a region linked to depression. 4 of 6 patients had remissions of their depression. This provided evidence that directly modulating brain activity could treat psychiatric disorders. Since then, DBS has been tested for OCD and Tourette's syndrome. However, a large trial of DBS for depression was halted in 2013 when initial results were not promising. Some patients reported side effects. This caused controversy over whether DBS really worked for depression. Interestingly, patients who had already received implants continued to recover over time. 2 years later, half showed substantial reductions in depression. This suggests trials need adequate follow-up periods. DBS is clearly effective for some patients, but not others. Figuring out why there are variable responses and reducing risks is important for the future of this approach. As with non-invasive brain stimulation, an individual's baseline brain activity likely influences DBS outcomes. But assessing brain states in real time remains a challenge for personalized brain stimulation approaches. While extreme life events can impact mental health, moderate changes in lifestyle may also influence well-being and resilience over time. Factors like income, diet, exercise, sleep, and stress management can impact the brain and body in ways that strengthen protective factors for mental health. Modifying these lifestyle elements may preserve or improve mental wellness. For example, chronic pain changes brain regions involved in mood, stress response, and emotion regulation over the long term. Lifestyle factors that reduce inflammation or support these brain regions may therefore benefit mental health. While genes and life circumstances are also important, controllable lifestyle choices provide an avenue for empowering mental immunity. Various diets, exercises, stress relief techniques, and routines may bolster resilience against mental health challenges through biological pathways. However, lifestyle impacts are often complex and individual. Modifying 1 or 2 factors is rarely a cure-all, and resilience also depends on non-modifiable risk and protective factors. Overall, lifestyle serves as an area where mental wellness may be preserved through balanced, health-promoting routines over time. Exercise and other lifestyle factors like diet, sleep, and stress management play an important role in maintaining mental health by influencing brain regions involved in emotional regulation. Changes to these lifestyle areas through improved nutrition, more physical activity, etc., can help boost mental immunity and make people less vulnerable to developing poor mental health under stressful circumstances. However, lifestyle interventions are not one-size-fits-all solutions and may not work or could even be harmful for some individuals, depending on factors like existing mental health conditions. More research is still needed to understand how best to utilize lifestyle changes specifically for different mental health needs. Studies show regular moderate exercise is generally associated with better mental health outcomes, like fewer days of depression or unhappiness. However, these benefits plateau after a certain amount per week, usually 45 minutes 3 to 6 times per week, and excessive exercise may not continue providing benefits or could indicate underlying mental health issues. Moderation and balancing different lifestyle factors is important. The study found that those who engaged in the highest levels of exercise reported lower happiness levels. This group may include more people exercising to manage stress or mental health issues. Exercise has wide-ranging effects on the brain and body through neurotransmitters, hormones, reductions in inflammation, and changes in brain regions related to mood and memory. However, the exact biological reasons for its positive effects on mental health are still unclear. Psychological factors like improved self-esteem and self-efficacy from exercise may also protect mental health. But the interactions between biological and psychological effects are unknown. Sleep is another important lifestyle factor for mental health. Poor or insufficient sleep causes a worsening of symptoms like anxiety, depression, and even psychotic experiences like hallucinations. Sleep problems are a risk factor for developing mental health issues and relapse after recovery. Better sleep may help build mental resilience against conditions like PTSD. Poor sleep is linked to most mental health disorders. However, the relationships between sleep and mental health are often circular. Sleep disturbances are common among people suffering from mental health disorders like anxiety, PTSD, and psychosis. Poor sleep predicts worse long-term outcomes for these conditions. Disrupted sleep negatively impacts brain processes related to cognition, mood regulation, pain perception, and more. This can increase vulnerability to developing mental health issues when under stress. Treating insomnia has been shown to improve mental health symptoms like paranoia and hallucinations in some cases. Improving sleep may boost the effectiveness of other treatments. Acute sleep deprivation can paradoxically improve symptoms of depression temporarily for some people. This may work by modifying circadian rhythms. Diet can also impact mental health, though evidence for direct causal links is limited. Very unbalanced diets that cause a deficiency could cause symptoms. Overall, healthy diets like Mediterranean may confer some protection against depression. Some small trials found Mediterranean diets improved symptoms of depression. Both sleep and diet are related to basic biological processes of survival, like energy regulation and homeostasis. Disturbances in these basic needs can indirectly influence brain systems underlying mental health. Dietary changes and supplements like probiotics have shown promise in improving mental health in studies, but the evidence is still limited and the causal mechanisms are not fully understood. Improved mental health from diet could be due to indirect influences on biological processes like inflammation, or potentially more direct effects on brain function. But this is difficult to prove without direct measures of brain changes. Probiotics in particular have shown potential to ameliorate anxiety and depression symptoms in animal studies by altering gut bacteria. Studies in humans show only small benefits so far. Healthy lifestyle interventions like diet changes can have side effects on mental health as well. Restrictive dieting is associated with increased risks of issues like poor emotion regulation, low self-esteem, and eating disorders. While dietary adjustments may benefit some through addressing nutritional deficiencies, the evidence is still inadequate to recommend them universally for mental health or claim specific superfoods will improve everyone's mental health. More research is needed to establish clear benefits, risks, and how and why certain diets might impact the brain and mental health. Eating disorders arise from a complex interaction between biological, psychological, and social factors. For most people, the drive for food and the relief of hunger are rewarding sensations, but for some with eating disorders, these sensations are experienced as aversive. Dieting can trigger eating disorders in vulnerable individuals by positively reinforcing food restriction and creating a habit. Over time, basic changes in how the brain processes hunger may occur. People with anorexia often find fullness uncomfortable and hunger relaxing, unlike most people. This altered perception of internal body signals could encourage starvation and food avoidance. Genetic differences may impact metabolism and increase susceptibility. When combined with dieting, biological and metabolic changes from genetics could set in motion physiological processes leading to disordered eating patterns. Public health campaigns promoting weight loss and healthy eating can inadvertently trigger or worsen eating disorders in those vulnerable, impacting population mental health. More research is still needed into the complex causes and experiences of different eating disorders. Mental health and illness are influenced by culture and society in complex ways. Diagnostic categories and understanding of conditions change over time and place based on cultural norms. Hysteria was a historically common diagnosis for women that is now seen as sexist. However, the underlying symptoms, like non-epileptic seizures, have cross-cultural consistency, suggesting a real medical phenomenon. Disorders can emerge and fade as cultures shift. Morgellons disease appeared as an internet-spread condition involving delusional parasitosis beliefs. Though advocates claim a parasitic cause, multiple scientific studies found no evidence of physical infestation. Social and cultural factors shape how disorders are experienced and attributed. They play a key role in mental health beyond just influencing diagnostic labels. Belonging to marginalized social groups increases risk of mental illness due to experiences of bigotry and oppression. While biological factors underlie mental health conditions, social and cultural contexts influence how changes are perceived and interpreted. This interplay determines the genesis and expression of many psychiatric disorders. Membership in a minority group can increase risk of mental health disorders due to potential trauma, bullying, rejection from friends, family, and other experiences. However, these factors are not always sufficient on their own and interact with other social factors. Discrimination against ethnic, national minorities has been linked to higher rates of mental health conditions like suicide and psychosis. Risk also depends on the local population density of minorities. Gay bisexual individuals also face higher risk of psychosis, depression, anxiety disorders due to experiences of bullying and discrimination. Schizophrenia and Alzheimer's disease were both once considered dementias. Our classification of disorders changes over time with improved biological understanding. Mental health disorders involve biological changes in the brain caused by both social environmental distal factors and proximal biological pathways. Though diagnostic categories are useful, underlying biological and symptomatic patterns often do not align perfectly with diagnoses. Treatments also work across diagnoses via common biological mechanisms. The boundaries between physical and mental illness are blurred, as all experiences involve biological changes, and even physical illnesses affect the mind. An exclusively mind category does not exist. Physical health conditions like arthritis pain and irritable bowel syndrome symptoms have been effectively reduced through psychosocial interventions like psychotherapy, showing the mind-body connection. Treatments have traditionally been divided between physical treatments for physical illnesses and mental health treatments, but this division is limiting. Some physical conditions respond better to mental health treatments, and vice versa. There is significant overlap between mental and physical health in terms of experience and origin. Functional symptoms can be indistinguishable from disease-based symptoms. To effectively treat conditions, we need a better understanding of the biological basis of someone's subjective experience of ill health, as this could be a cause or contributor. With a variety of proven mental health treatments today, the future looks promising for expanding treatments through new interventions like brain stimulation, psychedelic drugs, and lifestyle changes involving diet, sleep, exercise. For treatments to be most effective, we need to move beyond diagnoses and focus more on quantifying and targeting the specific underlying processes causing distress for each individual, not a one-size-fits-all approach. We also need to reject dividing treatments as psychological versus physical and recognize their interdependency, as everything in the mind has a real, measurable, biological basis in the brain and body. Future mental health treatments are unlikely to be a single breakthrough, but a systematic scientific approach tailored to individuals' underlying processes and circumstances, hopefully realizing the brain's ability to adapt and reconstruct well-being. Here is a summary of the key points from the articles. Major depression is associated with changes in pain sensitivity and experience. Patients with depression may show enhanced pain perception. Depression and chronic pain conditions often co-occur and share underlying neurological mechanisms. Stress and inflammation can also influence both depression and pain. Stress can induce both analgesia, reduced pain sensitivity, and hyperalgesia, increased pain sensitivity, depending on factors like stress severity and type of stress. Stress activates endogenous opioid systems, which modulate pain. Emotions like pleasure, happiness, and social bonding are associated with activation of brain reward and opioidergic systems. Endorphins released during positive social experiences like laughter can reduce pain perception. Inflammation has been linked to more negative moods and depression through effects on brain regions involved in reward processing and emotion regulation. Pro-inflammatory cytokines increased during sickness behavior or stimulation can transiently induce depressive symptoms. Visceral factors like core gastric rhythms and heart rate may influence emotional and affective responses like disgust and sensitivity to fear or threat through interoception, the sensing of internal body states. Cognitive and psychological factors interact with physiological arousal to influence emotional experiences. Moods and emotions arise from interpretations of bodily states based on contextual and prior expectations. So in summary, the articles discuss links between depression, pain, stress, inflammation, and reward-affective neurocircuitry, with interactions between physiological, cognitive, and social psychological processes, importantly shaping experiences of pain, emotion, and mood.